Hello, 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 hello. गुड इवनिंग मैम, कैन यू हियर मी?
हाँ चेतन, मेरा आवाज आ रहा है?
हाँ हाँ।
ओके ओके चेतन, क्वेश्चन जूम जूम में ना
हाँ
डॉक्टर
हाँ।
भक्त के लिए एनीवेज आस्क यू, टेल यू हाउ टू डू इट। तो वो उनको उनको इसी पहले भेज देना क्वेश्चंस, ठीक है?
हाँ चलेगा, ओके ओके। Good evening, sir. Can you hear me?
Yeah, good evening. I can hear you. Yeah, no problem.
Sir, okay.
Chetan,
Yes, ma'am.
yeah, I'm trying to call you. Just receive my call, na?
Yes, ma'am. Okay.
Yeah.
Hello.
Hello, sir. Good evening.
I think you received it, right?
So,
Phototherapy?
1 minute.
Anyway, it's there in
Yeah.
my, yeah, it's in there. Because my name spelling was still
So,
wrong,
sir, you
I had to change it.
you will be
My
presenting the slide deck,
I'll
sir.
be presenting
Oh,
because after sending it to you, I noticed that my name spelling was still wrong in the original slide deck. Anyway, I changed it.
okay. Okay.
I changed it. Right?
Okay.
Okay. Hello, Ramesh.
Hello, good evening, Kaushik. How are you?
Yeah, fine. How's the situation in Bangalore?
It is okay. Not bad.
Yeah. Now it is getting better here also.
Yeah.
In last 10 days, cases like from 20,000 per day, it has come down to 11,000 per day in whole of Bengal. So
Okay.
very strict lockdown going on. So
Karnataka, it is around 20,000 now. Yesterday it was
yeah,
20.
Karnataka was hit very badly at this
Yeah.
time, very badly. Anyway, hope
Now
this
the
again going to
problem is
change.
villages are affected.
Yeah,
See,
this
all
time all
have
over
moved
India.
from cities
Yes,
to villages.
yes.
Lots of cases in the villages.
So this is unlike the first wave. First wave, the villages were not affected.
Yes.
That is something to be worried about. It was difficult to like bridge these two, but So it may be a little lengthy, Dr. Bhakti. It may not be possible to finish in 40 minutes because all the COVID related protocol, you're muted, Dr. Bhakti. Can you hear me, Dr. Bhakti? You're muted.
Yes,
Yeah,
sir.
yeah. What I was telling that the COVID related protocol, all the procedure, phototherapy, what are the rules, and side by side coming back to fungal infection, these are two different
One
worlds.
minute, sir. I'm not able to. Just give me a minute.
Yeah, these are two different worlds.
Hello?
That is what I'm telling. That is what I'm telling. These are two different worlds. That COVID related, all the like a protocol that we maintain in our clinic,
Right.
and for the aesthetic procedure, and what has been maintained, what is okay, what is not, and also coming back and phototherapy and all other topics, and coming back to fungal infection, the how it is changing during this COVID era. These are actually two different worlds, two different topics. So this discussion will take a little longer than 40 minutes. That is what I'm telling.
Okay. Sir, as long as everyone is aligned on it, I'm okay.
Yeah.
You say,
Yeah,
okay,
yeah.
we'll just discuss
These
about
are
the-
our favorite topic. All our like esteemed panelists, we are experiencing this every day.
Yeah, sir, actually, a lot of thing is being said about antifungals nowadays. So I
Yes.
thought maybe the audience would be little interested, even though it is just at present, they are saying it could be, it might have a role, but most of them still have that
So I'll in the last
couple of minutes, maybe.
not couple of minutes, it will be dealt with quite long, but that is what I'm telling. These are two different topics. So we'll try to bridge this.
Sure, sir, no issues.
Anyway, where is
Yeah.
Abir?
Hello, good afternoon, Dr. Kaushikda.
Hello. Again,
Hello, Dr.
beautiful
Bhatt.
background.
Hi, Sanjay. Yeah, how are you?
How are you? I'm fine. How are you?
Yeah, fine.
We missed on that day. You were busy somewhere else, I think.
Yeah. I had this one on psoriasis and vaccines. I was doing a talk
Okay.
on that day. Yeah.
Sanjay,
So
Ramesh
part
is
would be
now
covered
the
here.
dean, I think. Ramesh, you are now the dean.
I'm a vice dean now.
You are the vice
Okay.
dean. So you know
Yeah.
all the responsibilities, all
Once
the.
I lose my vice nature, I will become dean.
But don't lose dermatology. So as in international society, we tell that only the person with vice, they become the vice president. Hi, Abir.
Yeah.
What
Hello,
we
Dr.
are
Abir.
Hello, sir, good
for
evening.
you?
Good evening, Abir.
Good evening, sir. Good evening.
Yeah.
Hello.
Abir.
Yeah.
Okay, Dr. Lahari,
Yes.
I have asked Chetan the audience questions he'll send to me, because most if it is repetition, then I'll just skip that and I'll send it to you, or I should put it on the group. How do you want?
Actually, it should be there in the chat box. You just give it to the chat box, because what I was telling Abir before you joined, just I'm repeating, as these two are two different topics, like our protocols and how clinical dermatology is affected, the phototherapy, aesthetic. Abir, are you listening?
Yes. And
Yeah.
the
your
presentation is
topic.
also in two parts.
Yeah.
The presentation is also actually in two parts.
Naturally.
First half.
And protocols, maintenance, and the aesthetic procedure, how it's being hit, and after that, this so-called our antifungal therapy, the fungal infection, the mask acne, the mask tinea. These two are actually two different worlds. That is what I was telling. So the discussion will take a bit longer, because these are questions in everybody's mind, and I'm sure. And after this, our panel discussion, if we have time, definitely, I'll take the question from the chat box, if these are not repetitions of what we have already discussed. All right.
Chetan,
Where is Dr.
Yes, ma'am.
yeah, so
Sadhuman?
chat box से sir directly questions लेंगे, ठीक है?
Okay, okay, ma'am.
Yeah, you can send to the chat box if needed. I'll take it up. And how many audience you were expecting?
Pallavi,
Any idea?
Pallavi,
Pallavi will answer after the session is over.
Yeah.
She doesn't want to.
And Kaushik, we are also audience.
Yeah,
So
naturally.
at least four of us would be there only.
Yeah. When Abid says something, everybody should be.
Yeah, that's
audience.
right.
Patiently here.
Both of you.
We're going to quote your study only, the one you published in Dermatologic Therapy. Most of the slides are based on that.
मर गया मैं तो भूल ही गया Actually, that was a brainchild of Nishant, and it was written by me because it had to be completely written by me. But the main idea was Nishant's, and I was not very much interested. But then I realized, ठीक है, चलो, these are the initial days of COVID last year. So whatever you write, it will be quoted. So it happened actually.
Actually, I reviewed that article, Kaushik.
Oh, देखो. So it's all in-house game.
Sorry, Dr. Bhakti, I missed you. I was calling Dr. Pradyuman to join the platform.
Yeah,
So what was the question? I missed it.
sir is
No. How many we expect? Audience.
Sir, usually, the audience is between 250 to 300, sir.
Okay.
Usually. Yeah.
Okay.
Yeah.
Okay. So Pradyuman was missing on that dry run.
Yes, sir. I had a word with him after that. I called him to update about the flow. And since it is Zoom, most of the doctors are already used to the Zoom platform.
Yeah. They will join. They will
Yes.
join.
Yeah, sir, he's trying to join actually. So he's having some problems. So Chetan is contacting me right now. So he will join in a couple of minutes, I think.
So the flow, if we repeat, just Dr. Bhakti, just tell me.
So I'll introduce
The panelist.
Yeah, the panelists. I'll hand over the session to you, and then you hand it over to Dr. Saraswati. Yeah.
Okay.
And after the question answers, then just a vote of thanks. And
Again by you.
Yes.
Okay.
Actually, today we had vaccination drive at Lupin.
Excellent.
So, I just hurriedly came back. I didn't even get time to change. I just wanted to make it on time.
So you got your shot today?
Yes, sir, for sure.
Very good. You got the first shot?
Yes, sir. Last time I did not take.
Oh.
I wasn't well.
Covishield or Covaxin? Which one?
Covishield, sir.
Okay.
Now
We all have taken. We are due for booster dose now. My second dose was in February, second week.
Yeah, my second dose I missed during the February, Ramesh, due to my eye surgery. So it was fashionably delayed by from 4 weeks to 6 weeks.
Okay.
Then the government also revised its schedule.
Yeah. We took at the end of 4 weeks.
So that time it was 4 weeks.
Yeah.
So the hospital, Apollo was repeatedly calling, Dr. Lahiri kahan gaya? मैंने बोला, देखो, I cannot go now. I am on the prone position, not for my hypoxia, but for my eye surgery. So when I reached, it was 6 weeks. And next day, ICMR introduced the 6-week schedule. So my DMS told, Kamal ho gaya, you did it on 6th week, and now the whole India is doing on 6 weeks. Now again, it is delayed to 12 to 16 weeks.
12 weeks, yeah.
Now it is, they say, like today, when I was talking to the doctors, they were like, it can get extended up to one.
Actually, the next extension will be even more interesting. You take one shot in this bath and next shot in next bath. So it will protect you in the next 7 baths.
Right, sir.
So 5 p.m. Can we start?
Dr. Pradyuman. We'll just wait for a couple of minutes. Maybe he'll join.
Chetan, Chetan, are you there?
Did you have a word with Dr. Pradyuman Pallavi?
Yes, I called him. So he was trying to join, but he's facing some technical problem. Now Chetan is helping him. I think he is with him only
Okay,
now. Amrish, are you there? Amrish?
Chetan this side.
Chetan, I think Dr. Dipesh is in attendee link.
Yeah,
Please join.
yeah,
And what
I
about Dr.
completely.
Pradyuman? What
Actually,
about?
there is some internet issue, ma'am. That's why sir is not able to connect. He's trying to another connectivity.
Okay, fine. So what I'm thinking, Dr. Bhakti,
Okay.
we can start and in between Dr. Pradyuman can join. I think it will take a 5 minutes, but by that time we can we can
Okay.
start. Yeah.
Sure. Okay, fine. Chetan, let me know when you're ready.
Yes, ma'am. I just make you live and let you know.
Yeah.
चिक्की खाणार चिक्की मार
Pallavi, you're unmute. Hello.
Yes.
How? Okay. Okay. Fine. Okay. Yeah, thank you. Okay. Good evening, everyone. I'm Dr. Bhakti Zadhav, Manager Medical Affairs, Lupin. I welcome you all for this very interesting webinar on emerging trends in dermatology in COVID era. Today we have with us our moderator, Dr. Kaushik Lahiri, who is a professor and senior consultant dermatologist at Apollo Gleneagles Hospital and the medical director at Wisderma, Kolkata. We have with us our speaker and panelist, Dr. Abir Saraswat, who is a consultant dermatologist at Lucknow, and Dr. Ramesh Bhatt, who is the Vice Dean and Professor at Department of Dermatology at Father Mulad Medical College, Mangalore, Dr. Sanjay Rathi, who is a consultant dermatologist at Siliguri, and Dr. Pradyuman Vaidya, who is a consultant dermatologist at Jahangir Hospital and Dinanath Mangeshkar Hospital, Pune. I welcome you all for this session. And with that, I hand over the session to Dr. Lahiri. Over to you, sir.
Thank you, Dr. Bhakti. So for the next 1.5 hour, we'll try to take you through a very interesting topic. And first, Dr. Abhi Saraswat, one of the best brains in dermatology in India, will elaborate about the topic today. that is how exactly in this COVID era it is shaping our dermatology practice, and with special focus to definitely fungal infection, antifungal therapy. But as I have already discussed, that these two are two little divergent topic, but we'll try to bridge this together. And now Dr. Abir will elaborate this, and after that we'll have a very interesting panel discussion with the extremely erudite panelist, Dr. Ramesh Bhatt, Dr. Sanjay Rathi, Abir definitely, and Dr. Pradyumna Mehta. So over to you, Abir.
Thank you very much, Kaushikda, for the kind introduction. I will do the honors of just starting the discussion off by giving this short presentation. I'll try to keep it as short as possible. So these are some of the emerging trends. Some of them are established, some are still emerging, some we don't understand very well at all. But whatever we know about what is changing in the world, especially the world of the dermatologists due to the COVID pandemic, this is the situation from 10 days ago. It is better in some sense now. In the last 10 days, at least in India, it's coming down sharply. But you can see the numbers are very, very big. In India, by whatever data collection methods we have, we've had 2.5 crore confirmed cases and almost under 3 lakhs total deaths. You must have read in Times of India today, a very well-known epidemiologist saying that these figures may be an order of magnitude wrong. So you can add one more zero if you are pessimistic, or you can choose to believe them as they are. We all know the good news of the last 15-20 days, that numbers are finally going down pretty sharply, as was reported by many people who were doing mathematical modeling of the second wave, with the additional insight that they had of the knowledge that they had accumulated over the last 1.5 years. What are the changing trends in dermatology practice? This was a study published last year. Total number of hospital admissions have decreased. That is absolutely logical, supposed to happen. Admission rates for acne, dermatophytosis, benign neoplasms are significantly lower. These conditions as it is don't have very high admission rates. Contact dermatitis, acne with dermatitis, cicatricial alopecia, lichen planus, and zoster significantly higher. Some of these we can probably explain. Some of these I think Kaushikda will grill us later on to try and explain why this should happen. The rates of biopsy, electrocautery, aesthetic procedures were decreased significantly, perfectly understandable. So there are various study reports that have captured an essence of what has happened to the dermatology practice. There has been a huge disruption. So this has been an opportunity for many people. This has been a loss for many other people. So the people who are technology savvy, people who run dermatology companies, or even dermatologists who have a very diversified multimedia kind of practice, who maybe sell their own branded cosmeceuticals online or through their chains or through their clinic, they have had a huge upside. And of course, all kinds of other people, non-dermatologists, other companies, quacks, etc., have taken an opportunity to build up their online presence and sales and practice, as more and more consumers are unable to go out and they seek all sorts of dermatologic and cosmetic advice online. And of course, the pressure to look good has increased on Zoom video calls because the face has become even more in focus. What you're wearing doesn't matter. Your jewelry doesn't matter that much, except for the one that you wear above your neck. So the concentration and the preoccupation with your facial appearance has increased a lot. And that includes hair, of course. So this was a big study. There was an uptick in the demand for cosmetic procedures. Whether we were able to fulfill that demand or not is a different matter. And if there is a demand, then something else will take its place. So obviously people were buying all sorts of cosmetics and stuff online in order to look good for calls. Botox became much more popular because the most common indications of Botox are on the forehead and the eyes, and these are the two areas which are not covered by masks. So I would presume that the poor nasolabial fold, where most of the collagen, where most of the hyaluronic acid injections go, that would have noticed a downturn because that area is not visible. And of course, the eyes and the forehead, where the Botox goes most often, that has seen an uptick because that's what's visible. Aesthetic dermatology procedures, of course, have taken a backseat because of the reasons that I said just now, and also for the fears from the dermatologic practitioners as well as the paramedics associated with the dermatology clinics. Till 3 months back, 4 months back, they did not have any vaccines available to them. They were scared for catching the infection. Even now, vaccination is spotty and slow. There is a lot of barriers to vaccination. And of course, the time that is associated with these procedures, the close proximity, and most of these procedures take place on the face. The operator is really sitting very close to the patient. At least the operator can use some barrier protection, but the patient cannot. There are no 100% reliable ways of picking up if a patient is incubating or having an early infection. He may be afebrile. So all these uncertainties in mind, it is a risk which doctors understand very well, even if patients don't. Patients have largely begun to understand it now, but initially I understand from doctors who have a predominantly cosmetic practice that there was huge pressure on them from patients to perform their regular peels and lasers and various other types of procedures. And patients who had not suffered from COVID yet and had not seen the horrific second wave that we've seen now didn't really understand why their doctors were not doing it. These are just guidelines, what procedures to be avoided. I think rather than go into this huge list, common sense, any procedure that brings you close to the head end of the patient is to be avoided. I'm sure you can easily do pairing of corns or a procedure on the soles or the dorsum of the foot of a patient with a large amount of safety. Just switch off the air conditioner in your minor OT, open the windows, turn the fan on. Both of the patient and the doctor wears adequate protection. Practically zero chance of catching it. But anything that asks you to get close to the head end of the patient is a risk, especially if the face has to be exposed and the patient cannot be wearing a mask while you are doing the procedure. So that's just common sense. More invasive procedures to be avoided. Less invasive, maybe simple injections of Botox that take 2 minutes to do. Maybe you can go ahead. But this is changing now as more and more healthcare providers are getting vaccinated, more and more patients are getting vaccinated. But we must remember that vaccination does not mean the absence of asymptomatic transmission. So even if the doctor and the patient don't get infected, they may still spread it to others. And in India, the biggest chunk of unvaccinated population rapidly is our young children below the age of 18 who are not mandated to get the vaccine yet. Also pregnant and lactating women, where there are some conflicting guidelines, or even if there are guidelines which have come recently, patients are even more scared. So telemedicine, enter telemedicine, and we've all had a very steep learning curve. Those of us who were sitting on the fence about this had to jump in willy-nilly into this practice. We had no choice. Our patients could not reach us. We could not provide the help that we wanted to provide. And now we've seen the full pros and cons of teledermatology. It has exploded. Everybody has had to do it. Some people have exclusively shifted to teledermatology. If not teledermatology, then old-fashioned teledermatology, that is, sending photographs of patients on the email and then talking to them on the phone, etc. So those kinds of relatively low-tech solutions are also, I know a lot of senior dermatologists who are doing that, who are not comfortable with technology. And there are a lot of innovations taking place in data transfer, and unfortunately, a lot of unpleasant truths about the horrible quality of our internet infrastructure and are getting exposed. And also the small number of people who actually are computer literate or device literate, or who have the money to buy a smartphone. I was horrified to know that only 21% of people in India have access to a smartphone, far less a computer. So almost 75 to 80% of your patients are out of your teledermatology possibility anyway. So that's something to ponder about. These are India-specific problems. Even if they manage to connect what we believe we will be able to see, what we will be able to hear, we all know with our experience of the past 1 year, there are so many limitations to this. But yes, we have been able to provide a lot of emergency advice, a lot of good advice to our patients who are really in need with really serious skin problems. But there are a lot of limitations. And this slide shows you the limitations, not just precancerous and cancerous lesions, the difference between a piderous dermatitis and a herpes zoster, the difference between a mosquito bite and a chicken pox. The subtle erythema around the lichen planopilaris, mucosal lesions, genital lesions. There are huge black holes in teledermatology that just cannot be filled with the current technology and the current modes of giving this. But still, we've been doing it, and it's moving forward in leaps and bounds. I just hope that the quality of our internet backbone in our country improves. And of course, we cannot do diagnostic tests, etc., biopsies. For that, dermoscopy and all for this patient has to come in. Although some very innovative solutions for online remote dermoscopy are being done. I'm sure Kaushik Da is also aware of that. A few papers have been published, but still it is in its infancy. So these are just some common safe practices. I think a lot of this can be debated now that we know that probably surface transmission from surfaces is not extremely important. Airborne transmission and direct droplet transmission is much more important. But still, it makes sense in a public space like our waiting rooms and our consultation chambers to sterilize and clean our surfaces. But I think the manic intensity with which we started doing it last year, I know of dermatologists who are wearing shoe covers and sterilizing the whole table, chair, door, window, everything after every single patient. I don't think that is needed. Now, there were companies who were fumigating doctors' clinics with all sorts of chemicals which left behind very shady residues on every surface and claimed to protect you for the next 2 or 3 months. I think those kinds of shady practices are no longer needed. We know that common sense, PPE, distance, mask, shield are enough. Waiting area, I will not go into this. This has been gone into with enough detail, and we can, I think, cover this in our discussion also. Measures in the consultation room, avoiding handshakes, face masks. We've been going on and on about it. Keep away from the patient. If you have to examine, ask the patient to turn away. The patient should be wearing mask as much as possible. If a patient is showing you something on the face and taking his mask off, you should stay away. Your mask should be on. If you want to go closer, the patient should put up his mask before you approach them. So these kind of common sense precautions, I'm sure we all are taking. Now, what is happening to disease trends? So these are the skin manifestations of COVID. I'm sure you all have attended enough seminars on this or read enough papers on this. Suffice it to say that there is no single specific diagnostic rash that we have so far found, which is of any value from a dermatologist point of view. We would have loved to have a very classical rash, even if that was present in only 10 or 20% of patients, which we could identify and say, yes, this is the COVID rash, and confidently ask the patient to get themselves tested and expected with reasonable certainty that it will come positive. Nothing like that. The usual suspects of viral rashes, that is maculopapular rashes, urticaria, some slightly different ones, varicella-like ones, which we don't see that common, pseudo-chilblains, which there is a huge debate in India about, but we have seen livedo-like lesions, which are more common in admitted patients, and of course, other rarer morphologies are all seen. It is sure that they are related with COVID, but they are not sufficiently sensitive and specific for us to make a diagnosis. But many times, astute physicians and astute dermatologists have seen a sudden urticaria and ordered a COVID test and, picked up an asymptomatic COVID. Mask dermatosis and dermatosis related to PPEs, etc., have certainly become more common. So because of prolonged wearing of masks, the tinea epidemic has, even as it was quite common on the face, it's become even more common in the masked area. And mean duration of mask use is 6 to 7 hours per day. I don't know where this data has come from. I think the Indian laypersons, it won't be this much, but still, even intermittently, people are starting to wear masks. But certainly in doctors and healthcare providers, it may be even longer than this. And patients often reuse masks without daily washing. I'm sure when we see patients, we see all different types of homemade masks, very dirty looking masks that patients keep wearing, which they have not washed or changed for many days. They are mixed with other clothes. They are, not disposed of properly. Use of over-the-counter treatments, of course, is there. So all these problems are there. How do we manage them? We have to, in tinea specifically, if there's a family history, fomites, tight clothing, hot and humid climate, pre-existing infections, we have to all take care of that. The protective face covers, of course, if they are wearing and not noticing it, this may lead to a delay in diagnosis. And of course, we have to counsel them how to sanitize, how to handle the mask, how to use it, how to discard it, how frequently to change it. And of course, anti-inflammatory washes, etc. These may be helpful in mask acne. Most infections can be treated in the usual way. I will again not go into this, topical or systemic antifungals. We all know very well in the last 8 or 10 years how to treat tinea. The only thing is we have to look for if and ensure and find out if in that particular case, mask wearing or PPE wearing is contributing significantly to the problem, and make the patient aware of how to avoid it or minimize it. So these are the various points which we may discuss. We should discuss what is the current scenario, make them aware that there's a huge outbreak going on, so that taking a bath, keeping the body dry, storing and washing, fomites, everything, synthetic garments, this whole list we can go through with the patient. And most importantly, in the end, ensuring and telling them how important it is to continue treatment, even though the disease may appear to have gone away, and not to stop treatment until we tell them to stop treatment. Mask acne or maskne has been all over the internet recently in all sorts of non-medical forums as well, because a lot of patients started blaming the aggravations of their acne to prolonged wearing of masks. I think it's quite probable, and it is seen in many patients, especially in nurses, OT assistants, and even doctors who are doing COVID duties, etc., and wearing PPEs and masks for long periods of time, because of the increased sweat, humidity, retention, lack of the ability to wash face frequently, etc. And of course, because of this, the disruption in skin barrier also can lead to dysbiosis and the acne getting a nice moist environment to flare up. So this is mostly inflammatory. Mask acne should only be considered if you're seeing inflammatory lesions, mainly localized to the perinasal region or the perioral region or the medial parts of the cheeks. Sometimes frictional acne is seen around the ears, where the straps of the masks are impinging, but mostly this kind of acne is seen inflammatory in all the cheeks. So it is recommended that surgical masks should be changed every 4 to 5 hours. N95 masks should not be used for more than 3 days, that too with a gap in between to allow them for the moisture to dry out properly, for any viable virus on the outer surface to get devitalized. Washing hands before and after wearing or removing the mask. And of course, you could put gauze inside. I don't know how practical this is or whether it actually works or not, but somebody has recommended putting a couple of layers of gauze inside the mask to reduce the amount of water vapor that stays there. And of course, patients with oily skin need to be extra careful with cleaning their face properly before and after, and applying a non-comedogenic moisturizer. Oil control, don't wear makeup. Common sense advice: if you wear makeup and then occlude your skin, you are asking for trouble. Non-comedogenic moisturizer, right fit, proper fitting masks which are comfortable, not too tight, but don't leak air. And of course, fragrance-free, not detergent. I think this should be fragrance-free cleanser. Wash the mask. Yes, of course. The mask should be washed with a mild detergent and allowed to dry properly. This is interesting. Urticaria. A lot of people say that we are confusing common urticaria and attributing it to COVID. There are enough case reports now of a clear-cut urticaria being associated with COVID. Early stage, middle stage, late stage. It seems to come indefinitely. You cannot be sure. But it is definitely because of COVID, because even if you continue giving them the medicines that you're giving, it does tend to go away even with antihistamines or on its own. So we must recognize COVID-associated urticaria. And these are the various mechanisms. It could be either a non-immune urticaria directly caused by mast cell activation. This is probably the most common mechanism. There are hundreds of other viral infections. It's the commonest cause of acute urticaria. We know that. So COVID is just one more in that list of viral infections that cause acute urticaria. But of course, the ACE inhibitor through which the virus enters the cell or the immune complexes related to the ACE inhibitor and bradykinin system also may be contributing to it. Although I don't think this has been studied in a lot of detail because it's a minor manifestation and almost all patients doesn't need anything more than antihistamines. So this is just a case study that illustrates that a patient who had COVID and had other various comorbidities, definitely had COVID pneumonia, was given azithromycin, other antibiotics, hydroxychloroquine, etc., developed on day 3 of hospitalization, developed urticaria 5 days after the onset of symptoms. So, but the thing was, he was not allergic. These medicines could have been blamed, but again, he was given loratadine and the urticaria went away in spite of the medicines being continued. So this was definitely a viral urticaria, which if you want to really dispute, you can say that he may have had some other coexisting virus along with COVID, but still, it looks like COVID also is directly associated with urticaria. The management is normal. I don't think we can discuss this in the panel discussion later on, whether any of these patients really do need steroids for their urticaria. I have not seen COVID-associated urticaria severe enough to need steroids, although I've seen erythema multiforme, vasculitis, etc., yes, which were associated with either COVID or the COVID vaccination, which needed steroids, but not the urticaria. This is the single biggest problem, I think, that all of us have seen: overuse of sanitizers, soap, not just sanitizers, but soap and water, leading to a peculiar type of irritant contact dermatitis. I'm sure all of us have learned to recognize it very easily by now. Just the dorsal surfaces of the hand and the fingers are affected usually. The finger webs are spared. So this is the sanitizer one. And if the finger webs are involved, then that is the soap and water one. And very often non-pruritic. Just the patients are worried because the skin looks scalded and burnt and kind of dry looking. Sometimes of course, it can be itchy also. And simple moisturizing and making the patient aware that this is the behavior that's causing it. You need to cut back on the alcohol-based sanitizers and go back to your milder cleansers. Reduce the washing frequency to 3 or 4 times a day rather than 10 or 20 times a day. So this takes care of it. Wearing PPEs for a long period of time has led to its own peculiar problems, the most common of which is the nasal bridge dermatitis that is caused by the pressure because of the N95 mask. A lot of the better quality masks do have a foam strip there, but even then I have seen and personally experienced that it can lead to abrasions and even sometimes pressure ulcers over that area. Especially if you're wearing a hood on top, which doesn't allow you to sort of adjust the mask periodically. So persistent pressure can lead to necrosis. So a very high percentage of patients who wear PPE for long periods have seen this. Of course, dryness of skin, allergic contact dermatitis, tinea, all sorts of things. Diaper dermatitis. I know of laboratory personnel who wear adult diapers under their PPE suits so that if they want to go, they can go without having to come out of the ward. So occlusion, friction are the main problems here. Healthcare workers are the main sufferers. This we all know. Hand hygiene, how irritant dermatitis occurs. It damages the stratum corneum proteins, takes away the protective lipid layer, changes the pH, and of course then damage and inflammation starts. So frequent hand washing we need to discourage, tell patients to use the right kind of products, good heavy moisturizers, and of course the right kind of hand washing behavior. So you have to select less irritating hand hygiene products, fragrance-free, hypoallergenic, whatever that means. But fragrance-free, yes, you can choose. Hypoallergenic is a marketing term which you should not rely on at all. Of course, you can change your practices. Hand washing immediately before or after using alcohol product. Now people were doing this double kind of thing, washing hands and then smearing sanitizer on it. That should not be done. Rinsing hands, applying a gentle moisturizer on top. Don't don gloves while your hands are still wet. So these kind of common sense things, if we tell our patients, this can help a lot. And of course, apply moisturizer after taking off. Thick, greasy creams and ointments are of course better, but they are uncomfortable. All sorts of other occlusive ointments, emollients are available. But in my experience, whatever type of non-fragranced, good quality moisturizer you use, it works. The main thing is that the behavior that is causing the problem should be reversed and changed or modified. For people with highly sensitive skin, of course, atopics are much more prone to this. We may need to give topical steroids for some time, especially if it is itchy. But if it is not itchy, I have not been giving them steroids. Just advise and moisturizers and gentle cleansers is enough. It all goes away in a few days. This was a huge problem earlier also, and now people have got the perfect excuse. The government is distributing 2 to 3 different antibiotics to everybody like peanuts, free of cost. So of course, everything goes now. So there is huge fear of acquiring infections, decreased accessibility, self-medication, going to the pharmacist straight away anyway. The Indians are experts in that, but even more so now when medical stores are the only stores that are open and many doctors are closed. So that's the perfect excuse. What is being most commonly misused? This was a study done by Kaushikda and some other doctors from Bhopal. As expected, oral and topical steroids are the biggest chunk, followed by antifungals, because this pandemic may be only 1.5 years old, but our tinea epidemic is coming on to its 9th or 10th year, I think. Antibiotics, of course, we Indians love to pop antibiotics. Amoxicillin, clavulanic acid, and norfloxacin, tinidazole is our go-to drugs for everything under the sun. And these were expectedly high on the list of things being abused. And this was the kind of tinea that we were seeing because of steroid use. If he wears a mask, they may blame it on mask also. But we all are aware of this kind of tinea. We all know what to do also. So I don't think we should be telling our audience all this. And this is a theoretical slide that in vitro studies have shown itraconazole and remdesivir. Also the SSRI combinations are probably theoretically helpful, but this is purely speculation, not in the realm of actual therapeutics right now. Now coming to before I end, the most important aspect of vaccination, because this is the hot ticket item now. So please understand, there are a lot of other guidelines, but the ACR guideline is the simplest. Most of the immunosuppressive or immunomodulatory drugs that we use in the doses that we use them are fine for vaccination. They can be continued except for methotrexate and Janus kinase inhibitor, for which there's very clear that one dose has to be missed after each vaccine dose. For methotrexate, 1 week, so 1 weekly dose, and Janus kinase for 7 days. What is the basis of this recommendation? It is purely theorizing. And based on there's no studies have been done on this, that whether this 1 week gap is enough, but theoretically it seems like it should be enough to mitigate whatever effect they have. And these are based on very clear-cut reports. That I've just seen 2 studies coming out of, one out of New York and one out of England. They're not yet published. They're available online just 2 days back, which clearly show with a single dose of the Pfizer or the AstraZeneca vaccine, the seroconversion after about 6 to 8 weeks was about 90% in patients who were not taking any immunosuppressive, only to the tune of about 62% in patients who were taking methotrexate or cyclosporine, mostly methotrexate. So methotrexate definitely is reducing, and even they checked the CD8 positive T cell responses also. They were almost absent in the methotrexate group. Now, reassuringly, patients who were on biologics, both TNF and IL-17, seemed to fare slightly better than the patients who were on methotrexate. So guidelines will be, I think, changing in this. We may be adding more in the list of the drugs that should be avoided for 1 or 2 weeks after the vaccine dose, but this is currently methotrexate, Janus kinase inhibitors, and of course we know rituximab. So these profoundly immunosuppressing drugs like rituximab and IV cyclophosphamide, etc. anyway, and in the less immunosuppressive drugs that we are more comfortable with, methotrexate and JAK inhibitors. These are the 4 that we need to worry about. Everything else is. And what is the worry? I think it's very important to understand. Our patients are worried, and many times the immunization center staff sends them away if they see a dermatologist parcha in their hand. What are the patients worried about? They think that something horrible is going to happen to them. A horrible side effect is going to happen because they were taking these drugs. We have to explain to them that nothing horrible is going to happen. You may just not be as protected as other people, and you may need a booster shot later on. That's all. There is no horrible adverse effect why we are worried about these. None of these are live viral vaccines, so there is no fear of the vaccine virus, causing some kind of disease in the patient. So all those fears are completely unfounded. It's just that they may need extra doses of vaccines later on, and they may need to be extra careful and not develop a false sense of security that I have taken my vaccine, so I'm fully protected. That's the only thing. And in any case, we are telling even patients who are fully vaccinated and fully properly immune also to continue to take these precautions anyway. So there's not much difference there. So rituximab, like I was mentioning, it can be scheduled such that there is at least a 4-week gap. And of course, if it can be deferred, it should be deferred. And the vaccine dose should also be delayed by at least 2 to 4 weeks. So I think that is all. I've taken a lot of time. I wanted to leave more time for discussion, and I will stop here. Thank you very much.
So thank you, Abir. It was really quite interesting and enlightening. And I learned a lot personally, and as always, from all your lectures. I'm sure our viewers have also enjoyed your lecture. Now, if we can directly go to the panel discussion part. I hope these are visible, the slides?
Yes.
Okay.
Yes.
So as you know that the panelists, the 4 most erudite dermatologists from all corners of India, Abir, the speaker, Dr. Sanjay Rathi from Siliguri, Pradyumn, the great young dermatologist from the western part of India, and Ramesh from down south. So all set, and we can go with this masterclass. This is the emerging trend in dermatology in COVID era, focus on antifungals. So actually, this today's discussion, we may humbly remember that this India's COVID surge has killed more than 500 doctors and second hundreds of others since March, stretching staffs thin. So our discussion today, this whole program, may be dedicated to this departed souls, whom we have lost. Some were vaccinated, some were not. Last year, we have lost about 880 doctors all over India. So, and this 500 is just in last 6 weeks to 8 weeks. So this is how horrific COVID is. The backdrop, very nicely described by Abir. This is the COVID monster. The first wave, second wave, we are coming down from the second wave. It looks like a prehistoric, like a dinosaur or something, but we hope there is no third wave. We can only hope. And the effect is this on the economy. So COVID-19, it has stretched to COVID-20. It's now 21. So we don't know how many years will have to continue with this. The World Bank and credit rating agencies have downgraded Indian growth by fiscal year 2020 and also 2022. Lowest growth predicted in 3 decades since India's economic liberalization in the 90s. Within a month of unemployment rose in last 1 month from 6.7% to 26% in 19th of April. And I'm sure that when the May data comes, it will be even more serious, because now about 77% of India is still under the clutches of like some sort of restriction or the other. So during this lockdown, not all the government bodies are using this term lockdown. An estimated 14 crore, 114 million people lost employment. More than 45% households across the nation has reported. I'm sure this is not the correct figure. More maybe income drop has occurred. So this is how we fare worldwide. The hospital beds and physicians from South Korea, Germany, you can say India is here. So this is actually the backdrop. This is an old slide from the last year, estimated impact on our economy. And so how has this pandemic changed your practice? I'll start from Ramesh, if we take, how exactly it has changed your practice, very Ramesh.
Yeah, Kaushik, actually, I am attached to a medical college hospital as well as I do part-time private practice.
Yes, I do.
So as far as in the institution it is concerned, we have many of our residents and young staff are posted for COVID duties, and as far as the skin cases are concerned, we take rotation. In rotation, we are practicing. Instead of 4 per unit, now we are practicing only 2 per unit. The number of cases have come down drastically. It is during lockdown, it is around 20% of our original caseloads. And once the lockdown was lifted last year, so it was almost inching towards normal. But for the last 1.5 months, once again, the caseload has come down drastically. And as you have already pointed out by Abir and yourself, self-medication has increased a lot, especially in relation to dermatology creams. So, we are doing less procedures only when it is required. In fact, it had picked up for the last 2 to 3 months, but once again, because of the second wave, we have once again stopped the elective procedures.
Thank you, Ramesh. Pradyuman, what's your experience regarding this?
Yes, Dr.
The first wave and second wave.
Yeah, see, basically, I am attached to tertiary hospitals, which has having the largest load of COVID patients. Especially in Dinanath Mangeshkar, we had 650 beds dedicated to COVID and almost 200 ICU beds in that, and almost 137 ventilators we had. So a lot of COVID work was going on, and we roped in other specialties also. So I used to do COVID work there. So because of that, obviously the dermatology practice suffered a lot, and as rightly pointed out by Dr. Bhatt sir, our dermatology practice in the hospital, in the tertiary hospital, was down almost by 15-20%. Means it was up to 15-20%. But now, as the wave is diminishing, the people are getting more confident coming to the hospital, and it is gradually increasing. In my private practice, I practiced in the mornings as well as in the evenings, but now evening practice have stopped because there are obvious restrictions in the evenings. Only the mornings are allowed. So I'm managing all my patients in the morning. I'm giving appointment systems, and I'm managing my patients in the morning. Patients are more comfortable coming to the private than coming to the hospitals. That is the major trend which I have observed. Means whoever used to come to my hospital OPDs, they say we will prefer coming to your private OPDs. That is one thing. Yes. Afternoons or in the late evenings, I dedicate to teledermatology, and there also I give appointments, and I have started doing a lot of teledermatology. To be very frank, I'm not so comfortable doing teledermatology, but because that sense of treating properly, it doesn't come because we are not sure exactly are we understanding the disease properly, and are we able to counsel the patient properly. But that is the major change which has happened. Regarding the procedures, with due precautions, I do procedures. Not major procedures, but lasers I'm doing with.
We'll discuss in details. We'll have enough time to discuss.
Yes.
So point is very well taken. You're very categorically have mentioned how it has changed in the two waves, and your experience in a tertiary hospital, private, and also your the clinic practice and online practice. Sanjay, I would like to hear from you how exactly it has changed your practice.
Yeah, very truly. Means I'm in a private practice, so number of cases has definitely much reduced. In fact, from the patient perspectives, for any skin diseases, most of them, it is a benign for them. So economy is really playing a role,
Yes.
because if they are finding any pigmentary disorders or a cosmetic problem, uh, presently in a pandemic situation, they would be more focused on a different part of activities, so that their bread and butter and everything goes on. Uh, the benign condition of the skin comes next to. So that is why the number of patient has drastically reduced, unless until is there any emergency situation, like if they are getting any allergic reaction or urticaria. So this is what I'm finding in my practice. Regarding first and second wave, uh, in first wave, people have very religiously followed the lockdown. So number of patients were much less at that time, because they were not coming out of their house. But in second wave, maybe you can say before second wave, gradually people were starting coming to the clinic, because they are more comfortable coming to the clinic than going by a teledermatology. That is going to be my experience actually in private practice.
Thank you, Sanjay. Very nicely put. And Abir, you have elaborated everything in your lecture. Do you want to add anything on your personal experience on in your practice? How exactly it has changed?
Yes, I just wanted to emphasize on what Dr. Rathi was saying. I have been struck and I have been really saddened by the fact how many of my patients have lost the ability not just to pay my fees, but to even buy their medicines. And the single most important reason now that they say, when when I shout at them or when I get angry at them, that why have you stopped all your medications for so many years? You are in such a bad shape now. They just say, I didn't have money. And even shopkeepers, even people who were reasonably well-to-do, people who used to come in cars, are not
How
are
true.
not able to buy
Absolutely.
medicines.
How absolutely.
This is what I have been struck by. Regardless of how much we waive off our fees, even then, many times, many of them, they are able to buy medicines only intermittently. And our practice depends so much in so many chronic conditions on regular treatment. Otherwise, things go haywire. Pemphigus, psoriasis, eczemas, everything goes haywire if medication is taken for 3 weeks and then not taken for 1 week.
Exactly.
And we keep shouting at our patients for this, but now I can't. That's
True.
a very saddening thing that has happened.
Absolutely. So, though I'm not like a panelist, but still I may share my experience. I'm attached to a tertiary hospital, one of the largest in the Eastern India, Apollo, and also I have my private practice in the city and also in a district headquarter. So my experiences varied. Like in the first wave, as Sanjay has very correctly pointed out, the problem was less, and the fear was this much, a huge amount of fear. And this time, just before the wave started, unfortunately, the problem was huge. We all could see, all the dermatology, all the doctors, all the social scientists, everybody was telling that the huge tsunami is coming. But the fear factor, forget about the fear, but the apprehension was very little. And that added with us the mad electioneering and everything in some states in India. And so the COVID protocol was thrown out of the window, and now we face the situation. Now, the number of patients has suddenly dropped definitely during the last lockdown and with this lockdown as well. And what we did in our medical college, in our Apollo hospital practice, as Ramesh was telling, the number of faculties, number of doctors we are attending the OPD only on our on-call days, not all the 5 days or 6 days in a week. We are going, just suppose one or two doctors are there in the OPD. So there is no chance of like 100 of patients. In any case, they cannot come now. But if one or two doctors are there, the number of patients is definitely less. And now the number of patients is so few that one or two doctors are enough to manage this. And what we are doing, in addition to dermatology, from our forum, Doctors Forum, we are doing free teleconsultation service for patients who are in home isolation, who are COVID positive, mild or asymptomatic patient. For last 1.5 months, we are doing this as a philanthropic service, and this has given us absolutely free of cost, and it's a huge satisfaction. In my last 3 decades of medical practice, this is probably the best moment. So I have not earned anything out of it, but this is a huge satisfaction that as dermatologists, we are not supposed to wear PP and attend the COVID ICU and intubate the patient, but this is how we could help our patients in need. So if we can go to the next, now I'll come to Abir first. Have you seen a shift in ratio of clinical practice, aesthetic procedure, and surgical procedure in your slide? You have mentioned what was actually an eye opener, because last year what you told, we are all masked, so there is no chance of aesthetic procedure. So there is the Botox and filler are gone, dead. Your slides have taught us something new. So can you just elaborate a little further?
Yes, certainly the ratio of aesthetic procedures has gone down. At least in my practice, it was never very high as it is. Surgical procedures also, they have gone down. But what I have seen now, the pandemic is in its 15th or 16th month.
Yes.
How long can these issues be neglected?
Yes.
How long can patients say, how long can they postpone?
Screen time, all our screen time.
Yeah, and how long can they postpone their weddings or you know, their other occasions, or even if there is no wedding, why be apologetic about it? As it is, people are depressed, horrible, with relatives, friends dying all around. And we all know that body self-image is a big part of your self-esteem and big part of being happy and a normal functioning human being. If you are depressed about your condition and you can't undertake a cosmetic procedure that makes you feel better, even if it is subjectively only, not objectively very much, it weighs down on you. You can wait for 1, 2, 3 months. So what I'm saying is, I am seeing a renewed demand of these procedures in the past 15, 20, 30 days. Patients are saying, I have not had this now for so long, my laser hair removal. Now, I have patients who have saved money for LHR.
Exactly.
They've undertaken 4 or 5 sittings. Now, I'm infamous for shouting at them, why are you delaying your lasers? Then you will say that you've not got the desired response. They are unable to come for the past 3 months. Their money has gone down the drain.
Yeah, I'm also infamous for shout at the patient. Why have you come to the hospital? The pandemic is raging, and you're coming for such a small issue. You're coming for just upper lip. Why are you coming here? And they told, I have saved money for this, doctor. Yes. So it is needed, because I need to attend the online meetings and all that. I'm a teacher, so I need to do the online classes in front of my students. So I cannot appear in front of the like a Zoom meeting with a hairs on my upper lip. So that is a new world order, new like a paradigm altogether. And Pradyuman, what is your experience regarding this clinical, aesthetic, and surgical? Is it change in shift in ratio somewhere?
Clinically, yes, we are seeing all the routine cases also, but especially as you have rightly pointed, there is definitely a shift. But what kind of a shift I'm seeing now? Patients means they have got a lot of time because they are working from home. So they have got a lot of time to do all these procedures. So there is one class of patients who are willing to do all kind of procedures. They don't have any fear about this pandemic, and
exactly.
They are insisting, I want to do this procedure. There were many queries for hair transplant also. I said, Baba, I'm not going to do it in this situation. And there is one chunk of patients who are willing, no, they're forcing us to do the procedures. So that is also I'm observing.
So we need to remember that you are in Maharashtra, and in your locality, I think it was one of the worst affected part of whole of India. So there also the patients are thinking from that angle. Ramesh, what is your experience? I know that you are mainly in hospital, mainly in the medical colleges. Still, what is your experience?
Yeah, actually, during the first lockdown, we stopped all sorts of procedures. Yes. And once the lockdown was eased, we once again restarted. So all the procedures we started doing. But now once again in the second lockdown, we are doing only few. For example, if a patient comes with wart, we usually do only cryotherapy, or we prescribe chemicals for laser hair removal we are doing as of now. Even PRP we have stopped doing, and peeling also, chemical peeling also. Because face is involved. So it is basically only the basic practice that is prevailing as of now.
Exactly.
I think once the situation improves, come back. Yeah.
I'll take the link from the thread from your last comment to and come to Sanjay. Sanjay, do you think that those who are practicing for last like a couple of decades, like you, me, and others, like or even more than that, and they are a little well placed because the clinical practice will be there, like the disease dermatology will always be there, like the desired dermatology may be coming down, or as Abir was telling, it is coming in a renewed shape. But what is your opinion, like our younger colleagues who are essentially focused in aesthetic and cosmetic procedures, not on disease, not interested in disease dermatology, they are finding it difficult to sustain or survive during this COVID pandemic?
Yeah,
And the
Kaushik,
seniors a little better placed?
yeah, if I'll say it is a harsh only, but definitely like dermatologist who is totally engaged in an aesthetic procedure or a surgical procedure, they are having a tough time.
Very difficult.
Maybe that is my opinion. If anybody has taken a rented place, then it is going to be a more difficult to pay even the EMI and the staff payments. So that is what my feeling is. I am, even before a pandemic also, I am mostly a clinical practitioner.
That's
I
why
do
I
very
asked you.
superficial procedures only. So still I feel dermatologist, whosoever like is doing, they should always practice clinical practice also in their day-to-day practice, so
That's
that that can
That's
at least
correct.
continue and we can serve our patient.
That's correct. Very nicely. And what do you think? Like I'm taking the liberty of showing the photos of the very handsome
That's true.
your moderator. So the teledermatology. How important is teledermatology in the new normal? Do you believe that teledermatology will be new normal? Like I know Pradyumna does not like teledermatology that much, but how is the patient response to teledermatology? Pradyumna, if I come to you first.
See, though I said I don't like teledermatology, but it is going to be the essential part of our practice. And I'm thinking now to dedicate 1 hour or 2 hours of my routine practice also to teledermatology. Once the lockdown also opens up, I think there will be many patients across India or abroad who are gone. They want that kind of a consultation. So I think this is the time when we should start doing more properly and more focused teledermatology. That is what I feel. Though we don't like it, but it is going to be a part and parcel of our practice henceforth.
So I'll be very brief. Ramesh, do you do teledermatology? Ramesh? Okay, I think Ramesh is off.
Yeah.
Yeah, Ramesh, can you hear me?
All part of my practice.
Okay.
Yeah, I can hear you. Yeah. Actually, very small part of my practice is teledermatology. We have a few patients. In fact, when this lockdown, everything is started, I also joined app and then I was using that. But I found that it was very difficult for the patients to use. Not all, the one who are techno savvy, they were using it. Otherwise, most of them were happy either to send their photographs or making video calls or sending the photographs through WhatsApp. Only those things used to happen. And whatever the guidelines that were issued, I was following. I was not giving all sorts of medicine for during teledermatology. So
Abhi?
it is, I can tell that it is only 10% of my practice.
Okay. Abhi, there was a question from Dr. Punshe in Abnabati that are you happy about the legality of teledermatology? How you practice? I know you are tech savvy. You do everything. Like how exactly you are doing teledermatology?
I'm doing it through a dedicated app that, that the clinic management software that I use in my face-to-face patients also. It has a teledermatology application as well. So it is integrated with my overall clinic software. So it's easier for me. Somebody who's shown me in the clinic, if they want the next follow-up from their home, I have access to their previous prescriptions and photographs and reports, etc., that are there on my computer. So it's easier that way.
And
but
legally,
the barriers are
legally.
legalities are tricky. The government has left us in the lurch by putting those guidelines. There is a big etc. that I am sort of pinning my hopes on. If some patient decides to sue me, and they have an adverse effect of something, if I make a misdiagnosis, or if some patient says, why did you prescribe methotrexate to me on teledermatology, like Dr. Ramesh Bhatt says, the government has very nicely put in their guidelines, we can only write vitamins, painkillers, and similar things, etc. So I am reading a lot into that, etc. I'm hoping that in a court of law, I'm going to be able to say that etc. gives me some leeway. But it is legally shaky if you are managing seriously ill patients with serious drugs. So you have to do a lot of disclaimers, preferably print it on your prescription or whatever electronic prescription that goes, that if you have any adverse effects, stop immediately, come in person. This is just for your relief, symptomatic, temporary, and no more than 2 consecutive consultations virtual. After that, the patient has to compulsorily come to the clinic. Even if the patient doesn't follow this, I think we should all be writing this down, printing it, and trying to follow them as much as possible, because the guidelines currently are absolutely stupid.
Sanjay, are you doing teledermatology?
Yeah, very, very less oftenly,
Very less.
because in the place where I'm staying, because one limitation is definitely, as Dr. Avir has said, internet, basically.
Okay.
So that Wi-Fi connectivity is very less, but very less oftenly. And patients are also, means in our area, they are not very comfortable doing a teledermatology. Downloading a special app for that, I don't think it is practical for them. Whatever we are doing, they are more comfortable with the WhatsApp video call or sending a photo. So maybe for my follow-up patient of a pigmentation, acne, sometimes I can do, but for a first-timer patient, I normally try to avoid if they can come to my clinic.
Now I'll share my view. Actually, I started teledermatology very early last year. On 23rd of March, actually, it was legalized in India after when the first like a lockdown was imposed by Prime Minister, and the next day teledermatology was made legalized with lots of ifs and buts at what Dr. Abhi Saraswat very correctly pointed out. And I started with 2 platforms with Wisdom, and also Apollo has a very robust platform, and with all the disclaimer and everything. But I'll take it very positively, and surprisingly, many of my rural patients, they found it as a bliss, found this as a boon, because they don't have to come to the doctor's clinic, because there is absolutely no way, no conveyance, no bus, train, nothing is moving even now. So they find it very easy to communicate with the doctor by doing the telecom. They are insisting on WhatsApp chat, which is actually not the proper way, but very quickly, and in comparison to the city patient, my rural patient, they actually accepted teledermatology much better than the city patients. And yes, it's a problem, it's a challenge for the senior patients. But sometimes it so happens that suppose the patient is here in Kolkata, the daughter or son is in Pune or Bangalore, they are connecting, they are actually doing as the role of mediator, and they are consulting on behalf of their aged parents in Kolkata. So that is also happening. And the third part is in the earlier age, like when my grandfather used to visit to a patient's house with on a horse. He used to ride a horse. So now you are also reaching the patient's house. And over last 100, 200 years, all these medical colleges, all these buildings, hospitals came up. Before that, doctor used to reach personally the patient's house. So now again, we are probably reaching, that barrier is lost. And even I have the experience of a small child showing her kitten and showing how the amphan has distracted the mango tree, and all these things which are not relevant to his disease, is suffering from vitiligo. But this is how you can interact with a patient in his own background, his setting. When the patient is coming to your clinic, he's little nervous, is coming to the city or the doctor's chamber. But here you are actually there in the patient house, so that makes them more natural, more relaxed. So that is one part which came to my mind. So this is one aspect. Uh, and we need to teach the patients how to take a correct photograph. Repeatedly we need to tell, this is not the angle, you should change the angle, this is not correctly focused. So that takes a lot of time in dermatology. Yes. And Abir has already elaborated. But your views on performing phototherapy, I think this was not addressed in the lecture. Abir, during the pandemic, your views of performing phototherapy.
It was impossible during the lockdowns, because coming every 2-3 days a week during the lockdown was impossible.
I understand. Yes.
But after that, now after a long break, when a lot of psoriatics have gone out of control, a lot of vitiligo, good work done over months and years has been undone. Finally, we've had to start it, and I've started it. Just the machine, the handles, the outdoor and the outside and inside handles that the patient touches have to be sanitized every time, and the staff has to maintain. So a little bit of change in protocol. As it is, it's a private procedure. Patients used to stay away, so not much of a problem.
Pradyuman, you have started phototherapy?
If the patient is able to come to the clinic, targeted phototherapy as well as narrowband phototherapy, we have done with the due precaution, as Dr. Abir has said. But if the patient is able to come, then it is possible. Otherwise, handheld devices and all, to be frank, those are not so helpful. But whoever are willing, they have purchased that and they're doing it at their own place.
You're right.
So,
Ramesh?
Not doing that, but whoever is possible, they are coming to the clinic.
Okay. Ramesh, in your hospital, in your
Yeah,
department?
whoever can afford to come, yes. We have not stopped this one, phototherapy. So we are continuing. Again, the number is very less.
Hello. Yeah. Sanjay, do you do phototherapy in your clinic?
No, it is not there with me only, but I refer to them. Just one point I would just add in this. I agree to what Dr. Abir has said, but phototherapy, maybe a narrowband UVB for a psoriasis, it is a vaccine safe also.
Yes.
So this is one thing we can guide to our patient also. They can comfortably take the vaccine.
So I was actually going through a very interesting article published in JAD very recently. It has a recommendation for phototherapy during the COVID-19 pandemic. And as it's actually a letter to the editor, and very nicely it mentions that how it should be done. Basically, it is based on common sense, that you need to screen the patient properly, that and these are the points. If actually you need to weigh whether the phototherapy is really needed, if there is lockdown, the patient cannot come, blah, 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 everything. And screen for the symptoms. So you properly screen for COVID and all those things. And the patient, when patient is coming, actually should be alone. And if the patient is really a small child, then another one guardian is allowed. And disinfection, like the sanitization, every time they are entering the phototherapy unit, that is important. And the mask, wearing of the mask, except for if it is on the face, and like all these things, like there should be a proper bag to store all their clothes when they disrobe, and the bag is discarded at the end of the treatment. And social distancing should be maintained. And very importantly, what we also do, like there should be a space between two phototherapy patients. Like previously, what used to do, the patients are waiting in queue, and one by one they're coming into the phototherapy unit and going. Now you need to have at least a 30-minute gap, and arrange waiting areas which are 6 feet apart. Wear a mask, apply proper hand sanitizer. Though these hand sanitization and touching, these are again coming down, as Abir has told, that it is actually airborne. But these are the things, if you face any legal problem, these are the internationally accepted and published protocols that we need to follow.
Dr. Kaushik, can I ask a small question? Query just. Hypothetically, patient in an incubation period of COVID, maybe asymptomatic carrier.
Yes.
He has attended the phototherapy.
You can't do anything.
Yeah, and after 3-4 days, suppose he gives a call and tell that I am COVID positive. So what can be done with that machine? Yeah.
Sanjay, forget about that window of when the patient is after 5 days or 7 days may develop symptom. I was throughout my COVID infection, I was throughout asymptomatic. All my family members were asymptomatic, all were COVID positive. So if I did not test myself, I would have go out and go to my OPD. I'll spread the disease to my staffs, to my colleagues, to my patients. So I just did it because there was a advertisement in the newspaper that they can come and do the RT-PCR. I just did it. I was inquisitive and I found that I'm COVID positive. So the how many of our patients are absolutely asymptomatic? So you can't really do anything based on that. And now it is actually all the patients are COVID positive until proved otherwise. So it's not just within the incubation period, but there are many who are actually completely asymptomatic but COVID positive. The next question is actually related to all this. Your views of performing lasers during the pandemic, major concern when it comes to sanitization of instrument. How do you sanitize the handpiece? Do you still perform procedures like PRP and said? I'll come to Pradyumna first.
During the lockdown last time, we were not doing majority of the procedures, but over a period of time, we learned how to do the procedures, especially in this wave. When it was at the peak, we didn't do it, but now we have started doing the procedures with due precautions. Proper wearing of the mask, especially by the operator, is very important in this. And we are doing laser hair removal also, because especially on the face also, it takes very less time to do the procedures. So that is not a problem with due precautions. CO2 and all those kind of things with proper smoke evacuator, we are doing it. Legs, nobody is demanding much, but if somebody is willing, then it's not a contraindication as such. But as you rightly pointed out in the second thing, how to sanitize, that is very much important. And if you are doing it properly, then it's not a problem, because now patients are also asking, are you taking proper precautions for sanitization? And that was that's what means I explained to the patient, I'm sanitizing the instrument properly and it is safe for you to use it. And we are not giving immediate appointments. We are spacing out the patients also, especially for the procedures.
Thank you. Abid?
Yeah, a sterile glove. What I do for the fractional carbon dioxide handpiece is take one of the thumbs or fingers, cut it out of the sterile glove, and stretch it and put it on top of the end of the handpiece. And then you give a few shots. The laser burns a hole in the front, and naturally a hole opens up where the beam can go out. The rest of the handpiece is covered securely with that glove. And then you just throw it out after the procedure. So with ablative lasers, I'm sure even diode and diag, you can do that, because they will also heat up the latex, and within a few shots, they will burn a hole in the tip of the glove.
Nice tip, very nice tip. Yeah,
that's a good way of using it. Apart from that, common sense precautions, your technicians should be aware. Many times I have to stand and see whether they are not wiping their face with their ungloved hand in between. The air conditioning is sufficiently. Now here, there is a problem. You cannot do it without air conditioning. And otherwise, I have stopped air conditioning in my waiting room and in my consultation chamber and switched on the exhaust fans, etc., so that the air circulation is there. For laser procedures and phototherapy, a tremendous amount of heat is generated. Everybody will be uncomfortable. They'll be sweating. So air conditioning needs to be on. Which is a risk for COVID spreading. We know that for hours after the procedure. So this is a very difficult compromise. I think we have to think about it.
So any one of you were still doing PRP or trades during the COVID era? Any of the panelists?
Yeah, I'm doing PRP for hair. I don't do PRP on the face. So the advantage is that while I'm doing it on the scalp for alopecia, I can ask the patient to continue to wear. And if they're wearing a poor quality mask, I give them an N95, which is properly fitted from my side.
No point wearing the linen mask, right?
Yeah, to protect myself.
Right.
And then I'm doing PRP on the scalp.
I'm also doing PRP, but not threads.
Okay, okay. So we are moving to the
We are
next.
also doing PRP. Yeah.
Ramesh, you are doing PRP, and any point you want to add regarding
Yeah,
the
yeah,
lasers and
we do. Yeah.
dermatoscope, especially if we are doing it, like
No, we are
sanitization of the lasers and
now during
dermatoscope.
lockdown. We are not doing. Otherwise, we are doing all the procedures.
No, this is all entirely focusing on this pandemic era. You are not doing that's what. Okay. Regarding the procedure, what is the protocol to be followed in the elective surgeries? Where point to be considered are selected for surgery, the precautions to be taken during and after surgery. So again, if I come to Pradyumna first, because I know that you are doing most, you, Abir, you are actually very active in the procedural dermatology.
See, in elective surgeries, which are the very much essential surgeries, that only I have done. To be very frank, hair transplant, I am strictly avoiding in this pandemic. People are insisting because they are working from home and they are willing to do it, but I am not doing it because the exposure time is too high and we are doing everything near the face. But yes, I have done vitiligo surgeries because those girls, boys are going to get married. And not extensive areas, but smaller areas. In this, I'm doing elective surgeries for vitiligos. I have done. I'm not doing RT-PCR or anything for those because those are not very invasive and not so much time consuming. So I'm not doing RT-PCR to those patients. But yes, of course, I'm asking the history and everything. And if the patient is not having, then I'm posting, but not too many.
Abir, actually, in the Western literature, for anything, any procedure, if you attend the doctor, if actually in some areas in UK, if you want to get an appointment to the doctor, you need to come with a negative report. So that is how like apprehensive they are. The whole world is going that way. But in India, we cannot do that. What is your experience like?
Sir, I'm so sad to say, and I'm sure in your state also,
Same.
This is what exactly the government is doing. Even if the biggest COVID government hospitals, the poorest person in the country cannot even enter the main gate without a negative COVID report. And a huge dhanda of fake negative reports has.
And even if the person is having a myocardial infarction, even if the person is having a rupture appendix, burst appendix, and they are insisting on having a negative report, and that is inhuman.
Yes, so many patients have shown me COVID negative reports that they have bought for 500 rupees from a pan shop just outside the gate of the hospital that sells these reports. They have a small printer behind and they just print out a COVID negative report. So this kind of scam government has unthinkingly done, and it's happening. What I do, I'll tell you. If anybody wants to, they can contact me later. I'll give you the details. Actual rapid antigen test kits cost about 80 rupees per test. You can buy a box of 25. If you are scared, if right now it's easier. I tell my patients, if you want and you are more than 18 years of age, somehow manage to get at least one dose of vaccine, show me the vaccination certificate. Then if they give me a history that they had some kind of sniffles or cold or something, if there is a doubt, or if I'm going to work on an unmasked face, one or two cases, I do a rapid antigen test in my clinic.
That's all.
It takes 10 minutes to do.
That's very smart. That's very smart.
I don't even charge them for it, and you can save yourself. But in general, if I cannot operate on the patient while the patient and myself are both wearing masks, then I don't do it.
Sanjay and Ramesh, you want to add anything on it?
Yeah, truly. So even in my area, means getting a RT-PCR report, an honest report, it is going to take 3 to 4 days to get the report.
Yes.
So if the patient is in a, no point doing that only.
Ramesh?
Yeah. As far as we are concerned, we only take. Yeah, in our hospital, we have for example, not for our department, for any emergency surgery, we have a separate COVID OT also. So even if the patient is suffering from COVID, in fact, I had a patient recently, a patient of hydrogen suppurativa. She came to us with the big abscess and I referred her to surgery. And when we did this rapid antigen test, it was positive. And then they have operated in a separate COVID OT. So in the hospital, we have a separate COVID OT. And then later on, they are shifted to the areas where there are exclusive COVID patients. So that is in the hospital. And as far as the clinic practice is concerned, I'm not asking for any RT-PCR test, only patients who do not have any symptoms, and when they can wear a mask. I have done biopsy, I have done cautery, all the other small procedures I have done. In fact, I would like to tell you that once I did a biopsy for a patient, and after 3 days, the patient's bystander came and told me that he is COVID positive. And fortunately, I had taken my vaccine about 2 weeks before I did the procedure. Of course, nothing else happened. So that was the one of my experience as far as a patient who was probably, he didn't have any symptoms of COVID. But after 3 days, he developed, and then the test was done.
So another reason why I kept this question is actually in our hospital, and I'm sure in other hospitals too. Suppose it's a 10-story hospital. All the floors are taken by COVID, and 1 or 2 are for emergency patients and for non-COVID cases. And in some hospital, there is no non-COVID beds anymore. And all the OTs are actually COVID OTs. And all the elective and cold OTs are cancelled. And now all our dermatology OT are actually elective and cold OT. So they have not told us directly to shut down the dermatology OPD, because that generates like a revenue for the hospital. So, but they have overall, there is a blanket ban on any elective surgery in the hospital. So this is all over India, this is happening. And these are the this is not my slide, taken from the slides of the last wave. I don't know how much relevant these with our recent knowledge about the surface transport of our transmission of COVID. The machine body have to cover with a disposable sheet for each procedure, leave exhaust fan open, discard sheet appropriately after each procedure, clean with sodium hypochlorite after each procedure. We were mad actually, as Abir told, disposable shit for the body of the laser. I don't do this, and leave out the exhaust. Yes, always we do it. Make patient wear a gown, and it is done if it is on the face and other body parts. But otherwise, the masking of the patient is absolutely needed. Machine tubing articulated arm, clean with sodium hypochlorite, 1% or 70% ethyl alcohol before and after treatment. Lens optics cooling tape, 70% ethyl alcohol before and after each treatment. This is the basic protocol that were followed last year, even now, and 70% ethyl alcohol before or after each procedure of the touching screens. And the staffs should be given PP. Yes, naturally they are on PP. And remove peeling stickers, clean every like a crevice of the contact surface. Touch screens are a source of infection. Well, that was the belief last year. I'm not sure how our infectious disease specialists will react to this. Strap should be sanitized. This is a real case scenario. Now, a patient is writing, doctor, I'm writing to you for my father. Your patient suffering from skin rashes for fungal infection. Now, coming to the other part. Now, we visited your hospital on this, and we are observing last few days, father is suffering from itching, trouble as a cheek and other body parts, and he is quite unable to consult with you physically as lockdown is going on. So we are sending the photos. So this is a real life scenario. We are all getting this. I don't know how this gentleman is really wearing a mask, but I know that he was using all this GM and NG and whatever, all the cocktail before that, because I had his reports. So I immediately told that actually this is for that reason. The industry has been witnessing a loss of business, and this trend expected to continue for the foreseeable future, at least 3 to 6 months. And the fact that the sector's costs are predominantly about 80% fixed, it is expected there will be losses and severe impact on cash flow. So this is how it impacted the dermatology practices. Clinical dermatology may continue to suffer due to lack of access of the patient to the doctors, aesthetic practice will be big time hit. That was our belief last time. Yes, flow of middle of income will vanish, and will restart regular clinic visits. They have already restarted. Dermatosurgery and scar lasers may take an initial dip, but this sector will again recover fast, as this is essentially need based. Almost all dermatology laser procedures fall in the category of non-emergency or non-essential procedure. This is how we used to sanitize and maintain the protocol in our clinic. This was our paper that Abir was referring to, like published in Dermatologic Surgery: Increase and Consequence of Self-Medication in Dermatology During this Pandemic. This is how the FD, all the tinea and other like fixed drag rash, this happening. So mask tinea, all the photos I have taken from Dr. Ramesh Bhatt, who has very generously sent. Have you noticed an increase in patient who complains of skin disorder extended is a mask? Is it a concern for healthcare workers since they are using mask and PP for longer duration? In case of mask tinea, what is your line of management? If I come to Ramesh first.
Yeah, one thing is, you see, we are in a very humid environment in Mangalore, and it sweats a lot. So that may be the one aspect why there is mask tinea. And usually they will have other foci of this one infection. So what I ask them is to have a cotton mask, and if required, to change it frequently. And if they are using cotton mask, it has to be washed, and the properly dried up mask have to be used.
But
so that is my advice for them.
Any protection from COVID. Cotton mask, you will not give any protection from COVID, because they can use the surgical mask.
Yeah. That is also there. Yeah. And surgical mask is much better. Other aspect is many of them wear very colorful masks and synthetic masks. That will increase all these problems.
Absolutely. Absolutely.
So that is the advice that I give as far as masks are concerned. This patient also had tinea.
So, Sanjay, do you think that the only tinea is happening like with a mask, or you are having the seborrheic dermatitis and the psoriasis versicolor on this area and patient wearing mask always?
Actually, the now miss what I'm feeling is the trend is that anything happening in the mask area is now said to be because of a mask. So one example is a mask acne. Now even the mask rosacea has come. That is the second thing. And as rightly you said, the seborrheic dermatitis, more commonly seen in the nasolabial fold.
These are all Ramesh Bhatt's photo.
So this is what basically my feeling is, that anything because of a hot and a humid climate and the friction induced diseases, they are going to increase, as we all know that is going to increase because of a mask only.
Correct.
One thing I'd like to add.
Yeah, please do it.
That was an interesting paper written by our Dr. Mutalik sir, and he observed Kibnus phenomenon in the area of tying of mask, and there was psoriasis exacerbation in that area. He has published that paper.
Okay, excellent.
Just one thing. We have in eDermacon, we are having a poster, actually, e-poster for this. Means we have reported a cubnernization and the pseudocubnernization because of a mask. So basically, we have reported one for the psoriasis and one was for the verruca plana. So in recently eDermacon, it was there as a poster.
So our COVID papers are getting more and more from this part of the world. That is also very encouraging trait. Abir, do you believe in mask acne? Is there anything called mask acne or maskne? Or it is actually acne which we are giving a colorful name?
Yeah, I mean, I've been reading about this and I've been trying to look at my patients for the past many months and trying to identify whether, I can, with some confidence in all good faith to myself, say, yes, this is definitely aggravated by a mask. No, not a single case have I been able to convince myself 100% that masks are the culprit in this. Although many patients have said, ye mask pehnne se ho raha hai, shayad. I said, okay, shayad is fine. Even masked tinea, I have not seen a single case where I could confidently say that this tinea is because of mask. The only thing I have seen is, of course, apart from the cobnarization of things, which do not happen with mask, they happen with either the edges or the straps. So that, of course, yes, we all see those erosions over here. We see various things cobnarizing over here where the straps are or the edges are. But I saw one patient who had a lot of pityriasis versicolor lesions localized around the nose, which I possibly thought could be because of mask.
Yeah,
Nothing else I've been able to conclusively.
You can see in this picture some
Yeah.
unusual
Yeah,
area, but actually, yeah,
the right one. Yeah, the right. Mine was even more impressive. He had very few lesions here and here, and he had a lot of them.
So that can be due to the mask, definitely.
That probably was. But the tinea and acne, I'm not sure. Maybe some people are experiencing aggravations. I've also seen some doubtful aggravations around the nose, but I'm not sure that the mask was the major cause.
But I'm not convinced about the mask acne. Actually, I did not know about this term mask acne till a patient told me, "Doctor, I have mask acne." So I never knew. Some of the patient told that you know about that. I always had pimples. I never had acne. So I never knew that there's a difference between acne and pimples. The patient will always teach you. But this mask acne also something that I came to know about the patient, and they're absolutely convinced because of this Google University training that there's something called mask acne. And this is another issue that is coming, and COVID-19 positive. Some patients are like very much methodical. Actually, this patient a little dangerous, and because they keep everything recorded. This is actually they are sending by mail and also by WhatsApp that I consulted on this doctor, took medicine, and fever continued for 10 days, still May 3, and underwent CT scan. Report is attached. That is positive. Last medicine taken per prescription by this doctor. Now started observing rash all over the body. It aggravated over the next couple of days. Took couple of Allegra, but it did not help at all. Now click pictures of the rash, attached snapshot, underwent blood test, report attached. Now consulted this doctor. He give Monter LC. So after almost 1 week of taking Monter LC once daily, no help. Like as per the GP, Monter LC is the ultimate for the urticaria and all that. So the current status, excessive rash persistent, rash even observed in the palms and hands and the soles. And this is in front of you. And yes, I'm convinced that urticaria, yes, definitely, it is related to, it can, some of, I remember one patient, one nurse from the PG hospital here in Kolkata. He came with his boyfriend, a doctor, and they just entered. And I asked whether you have done your RT-PCR. They were shocked. Why should I do? I'm working in a hospital which is non-COVID hospital, and was like this kind of vibe all over the body. And they were unpleasantly surprised that the next day, both the doctor and the nurse, they were actually COVID positive and with a very high CT value. So how frequently do you find urticaria in COVID positive patient? Challenges you face when treating a patient with urticaria, and what is the line of management in some such patient? If I come to Sanjay first.
Just my personal experience, just last week only, one of my, he was related to me. Basically, he has given a clinical photographs of urticaria. He is having just a complaint of a myalgia 1 day before.
Yes.
And thinking of urticaria means it just came to my mind, why not we'll go for RT-PCR?
Yes.
The RT-PCR has been done and it has come to be a positive. So it was so very difficult to convince him also that
some
this may be a presenting
symptom.
Offended.
Some
that's
are
what
offended.
Only.
Why are you telling?
That's true.
I don't have fever. I don't have any, like yes. I just have a skin rash. Why you are telling for RT-PCR?
So that was the urticaria on the very first day of a symptom. So this may be one of the presentation, we can say that in the future that this may be one of the presentation of a COVID actually.
Yeah. Abir?
Yes, I've seen a few patients, and it should not surprise us at all. Acute urticaria, the commonest cause we all know is viral infections. This is another virus. Why should it not cause urticaria? Many people are very vehement in saying that urticaria is not. Why should, I mean, it would be unusual for this virus not to cause urticaria.
In our COVID and dermatology group, some of our very erudite friend had told that I have seen 6,000 patients and I don't think I have seen any skin rash or
Yes.
urticaria or anything. So that is
Yes.
actually two worlds. I don't know how this match. So you are
Absolutely.
convinced that it is related to COVID, right?
It can be related, and what Dr. Rathi said is a very good way. Although I mean, it may be not very efficient in picking up COVID, but still, if you want to suspect something, then if any patient gives the history of even the slightest of prodrome with the urticaria, then it's a
You
good
do a
idea
rash.
to have it checked out.
Yeah. And Ramesh, what do you think?
Yeah, as others have told, I also agree that urticaria is a part of viral infection, and sometimes secondary to drugs also, because they
That's a
see
good point.
after taking some antibiotics or antipyretics. That's what I have observed. So I have seen urticaria, I have seen edema of the hands also in patients, even when it is subsiding, there is scaling, how we get in Kawasaki disease. In a similar way, there is scaling of the palms and soles also. That is also I have seen.
Well, actually, that's probably after subsidence of the edema, the peeling that happens, maybe. But actually, I don't know about Pradyuman, but I have seen patients who are admitted who have not stopped any medicine. But when you give some our fexofenadine or levocetirizine or bilastine or anything like loratadine, the patient responds to this even if they are continuing with all the medicine. What is your opinion? You are attached to a very big hospital.
Yeah, see, again, as others have pointed out, urticaria is a common feature of COVID presentation. What I feel, 2 days back only, I had a child, I had a reference urticaria patient, severe urticaria patient. I entered the room, I saw the patient, I said, Baba, we should do RT-PCR of this child. And unfortunately, it turned out to be positive. And all were shocked. As you rightly said, they were offended. We have admitted for the child for urticaria, and why are you suggesting RT-PCR? But unfortunately, that child, who was hardly 4-5 years old, he was positive, and all the other relatives also turned positive. So that is what we are finding out. One thing I would like to contradict you is
actually this children, this child, unsuspected child, they are the super spreader.
Yes.
So everybody actually cuddling this child, and all the family members are getting infected from that child. Yeah.
Yes.
Yeah. Continue,
I'd
please.
like to contraindicate in one point. Means I'm finding the urticaria patients, especially post-COVID also, they are very resistant for treatment. They are not responding to the routine line of management. Like we need to step up the dose. And in few of my patients, I can point out 2 or 3 patients, I had to give really high doses of antihistamines. Still they didn't respond. Then I had to give steroids also, and steroid also not a low dose, a proper dose of steroids, which was needed for that patient.
So
That's what I have.
Can you give cyclosporine in these cases?
I was thinking of giving cyclosporine, but fortunately, it responded to the high dose of steroid. Like
Abir, what is your opinion regarding this kind of like resistant cases post-COVID urticaria? Not usual urticaria, what should be the management, like a steroid or the second line of management other than this usual our histamine blockers?
I think our standard approach of 7 days of proper full dose steroid, something the 40 milligram prednisolone equivalent, is a better idea.
Want to go with the steroid, not cyclosporine.
Yeah, because we anticipate not more than 5 to 7 days.
Okay.
In worst case, and if this doesn't work, then I would think of omalizumab, not cyclosporine.
Right. Okay. So now come to the special case, like the chronic disease like atopic dermatitis, psoriasis, use of biologics in COVID. You have already elaborated because the guidelines of several associations, BAD, AAD, EADP, they have also changed over the last, even after the first wave, not the first wave of our country, first wave of their country, and this during the second wave, third wave, because the whole of Europe, they have already passed 2 or 3 waves. The guidelines to be followed in vaccination in case of CU and psoriasis. You can start, Abhi.
Yeah. As for the first question, how COVID affects the patients who have chronic disorders, I don't think directly it has any effect, but indirectly, because they tend to stop therapy and they are unable to, they are forced to stop therapy. And all guidelines say that at least for 2 to 3 weeks, you have to stop once they turn positive. So for that reason, it does aggravate, but I don't think there's any direct effect. There's no evidence also. Use of biologics in COVID, I've already said, apart from rituximab, out of the biologics that we use as dermatologists, only rituximab is of concern. There may be some coming reports which are blaming infliximab as well. But I think infliximab usage in general is going down in dermatologists, but infliximab and certainly rituximab we should be worried about, nothing else. And guidelines for vaccination, we should not be worried at all. I had a patient who I reported, he had very severe chronic urticaria. I was treating him with cyclosporin. He was barely controlled with cyclosporin. He took Covishield, and 2 days later, he had a tremendous exacerbation of the urticaria. I had to double the dose of cyclosporin. In addition, I had to give him steroids, and now I have told him not to take the second dose. So he already had chronic urticaria. So it can sometimes aggravate, but current guidelines are unless a patient has had angioedema or anaphylaxis, all other kinds of allergic reactions are considered mild allergic reactions, and under proper medical care and counseling, vaccination can be done.
Though it is not in the my set of slides, but I'll just take 1 minute and I'll just bounce my thoughts with Sanjay. That perhaps we all encounter lots of our patient with hair loss, like a telogen effluvium, like a huge hair loss in last 1 year. Like there was a editorial in New York Times that the whole globe, there was a cartoon, the whole globe, and the globe is losing hair. So it is that disastrous all over the world, and it was written that after the Second World War, due to the stress or other reason, the whole world has not lost more hair than this. Like, do you agree with this? Because I find it not only in COVID patient, but in patients who are never been tested, never shown any symptom, also are having, like, especially female hair loss. Hair loss is a major problem in last 1 year. Do you agree with this?
I will agree with you, Dr. Kausikda. Actually, after first wave, once the lockdown has been eased, once the patient has started coming, out of my 10 patients, 5 were having a problem with the hair loss.
Yeah. And Ramesh, what is your opinion? Very quickly, just we're coming to the last part of our discussion.
As you have told, it has considerably increased, not just in COVID patients, but also in other patients.
And this hair loss, it is very difficult to manage. Very difficult to manage.
Difficult to manage. And nutrition also may be another aspect.
The stress is causing a huge
nutrition and then their diseases.
Yeah. And Pradyuman, just one line.
Means if a patient of severe hair fall comes, I ask them, did you had COVID? And in majority of the cases,
exactly.
So
exactly.
Also is true.
All are telogen effluvium, actually.
Telogen effluvium, yes.
Right. Abir?
Yes, both acute telogen effluvium and acute exacerbations of chronic telogen effluvium.
So you're also seeing a lots of hair loss, right?
Absolutely, yes.
Okay. So coming to the last part, that is the management of fungal infection during tinea. And we are seeing some horrific photos, not only during the pre-COVID era, but also during this COVID era. And this kind of patients are coming to. What are the subset of tinea patient you are getting more now? The recalcitrant, post-COVID, diabetics, TCS abuse, extensive lesion, multiple site of involvement, any other? Like, I'll come to my friend from Siliguri.
I think the scenario is same, whether it is a pre-pandemic or a post-pandemic, but maybe I'll say during a lockdown or a pandemic period, topical steroid abuse is one of the important reasons still. And second is the non-compliance patient, basically. We have started the medication, they have found the improvement in the things, then the lockdown has come. So there is no continuation of the medicine. And there is a recurrence or a recalcitrant lesions comes out again only. And then they will go to the pharmacy because that is open in a lockdown area. Then definitely they are going to get a topical steroid combination medicine. So this is how the scenario is little changing. Non-compliant patient and a topical steroid misuse. maybe more commonly seen nowadays.
Ramesh, very quickly.
Yeah, whether you like it or not, Kaushik, what I have seen is that the cases of tinea have come down after
No,
lockdown.
why should not? I love to see that there is no steroid abuse. So, and
No,
there's
no,
no.
not because of steroid abuse, because you see, most of them develop tinea after excessive sweating. During lockdown, they have not gone out of home.
I tend to agree with you. Yes.
Are at home only.
They're all wearing lungis, not wearing trousers.
So that may be the one reason. Second, what I feel is that they have not come back to us, because they may be doing self-medication, or they may be continuing the same medication. But one of my patients who had very chronic tinea for years together, now he is free of tinea for the last 6 months. After
Was he COVID positive ever?
Yeah, after the first lockdown.
So no, he was COVID positive.
No, not related to COVID at all.
It's not related to COVID.
Work style has changed.
Okay,
After,
work style has changed.
this one, because there is not much sweating.
Amir, what is
because
your
of
take?
his work.
Which subset is reporting to you more?
Certainly. I was starting to notice very happily early last year, and I was commenting to friends also that some kind of steroid abuse seems to be going down. Slight awareness, even in rural areas, that these kind of tubes are bad. You know, they cause the tinea to get worse.
That was already happening before COVID.
That was happening before COVID. Yes. That had started happening, and unfortunately, a lot of it has been undone. I'm seeing again more cases because of
they cannot come to your clinic. They can come to the local chemist shop.
So that trend has reversed, sadly, somewhat.
Sadly, yes. So are you combining the oral agents or prescribing for a longer duration? If yes, what should be the most appropriate dose and duration according to your clinical experience? Sanjay?
Can I get your question again? Because I'm not
Are
getting
you combining, you can look at the screen. Are you combining the oral agents?
Two oral agents, or a oral or a topical?
Combine, yeah. No, sometimes the two oral agents are also combined.
Oh, no. I'm not at all in favor of combining two oral agents.
Okay. So are you prescribing the oral agent for longer duration?
Yeah. Instead of increasing the dose, I normally prefer to give up for a longer period.
And what should be the most appropriate dose and duration? Suppose we are discussing itraconazole.
Okay. Normally it is 100 to 200 milligram of itraconazole. I normally prefer, depending upon I see the weight of the patient also. Means if he's in an obese side, definitely a 200 milligram. 2 weeks normal duration. If the patient is responding to 70 to 80%, then I'll exceed for 1 more week.
Okay.
This is how I proceed.
Ramesh?
See, I start with 100 milligram only, except in obese patients, I give 200 milligram. And as Dr. Rati has told, I also give for a prolonged duration. I give up to 6 weeks. So only if they don't respond, then I change. Then of course, topical antifungals, both I give, both oral as well as topical. And I usually don't combine two antifungals. What I do, if they don't respond to one antifungal, I will change over to the other antifungal. And I use plenty of griseofulvin also, other than itraconazole.
Pradyuman?
I would like to comment on the previous question also, which subset is coming. Now, interestingly, family members are also infected because they are staying together.
Exactly.
So that subset also I'm seeing a lot. It's initially they were distancing and all those kind of things were there, but now as they are staying together, a lot of family members are getting infected. And as rightly pointed out by Bud sir, people are wearing loose clothes. So that subset also is there. It means whoever were very resistant tinea, they're also coming. Coming to this, I do sometimes combine oral antifungals in very resistant, very severe tinea, but not for a longer time. I generally combine terbinafine with griseofulvin, and then taper it off immediately once the response is there and continue with one line of management.
Okay, before I come to Abir, actually what I do is after complete like a clinically the disease is vanished, still I continue for another couple of weeks, if not more, of oral itraconazole, and then I stop. This is number one. And Abir, suppose if I extend this question, the patient who is resistant to the conventional itraconazole and tabinafine and whatever, so what you do in these cases?
In some patients, I have tried the super bioavailable formulation that has become available.
Yes, yes.
Even if they were not taking any PPIs or any other things that I could find out. And in at least 4 or 5 of them, I have found that they responded. So they were probably secreting less acid innately without, or they were not absorbing it well enough. So that was one approach. Another approach is either daily or every alternate day fluconazole.
Yes, I also do that. Yeah.
150 to 200 milligrams a day.
Yeah.
150 milligrams a day if the patient is obese, even 200 milligrams a day daily. That works. But topicals, again, my tendency is to give 2 different topicals to almost all patients of different classes, one in the morning, the other at night. And the duration of oral treatment is never less than 6 weeks. And yes, what Kaushik Das said is very, very important. In deciding the duration, we should always check for complete clearance and add 2 weeks to it, even if it takes longer than 6 weeks.
So this case is from pre-COVID era, and you cannot blame any mask for this case. And this is due to no point for guessing the topical corticosteroid abuse, which we see used to see in our daily patient when we had some patients in our clinic. And have you encountered any case of mucormycosis? I'll ask each one of you. Ramesh, what?
As of now, no.
That is a good answer. That is a very good, like I wanted to hear this. And Pradyuman?
Unfortunately, yes. In pre-COVID era also I have seen mucor case because I also practice into HIV. So one of my patient, I distinctly remember, he was a lawyer. He was a severe diabetic and he was on immunosuppressants. In that, we had to inoculate his eye. So that was in pre-COVID era. And as I'm working in a tertiary hospital, there are at least right now 40 to 50 patients which are admitted. And there were for some skin involvement, they thought whether it is herpes or something like that. That's why the reference was there. But I said, well, this is not herpes. And it turned out to be mucormycosis. So unfortunately, this I have seen.
Abir, your state was one of the most affected just in 15 days, 3 weeks back. Any experience regarding mucormycosis?
Yes. Even, I mean, I'm not attached to any teaching hospital or corporate or multi-specialty hospital, but even in my solo dermatology practice,
3 patients have come to me. 2 have been referred by anxious GPs, or even one was referred by an ENT specialist who was honest enough to say, I cannot handle this. And once in pre-COVID era, I had given posaconazole to one of his, I had arranged that drug for him. So he sent him to me. Although I couldn't treat him, I could just send him to the right patient, which I said the right doctor for you is a oncologist, because they are the ones who treat the maximum number of mucormycosis patients. So I just redirected that patient, but yes, I saw him in my clinic. So yes, they are there. 2 of my 3 patients were given very, very low dose steroids for very short periods of time, which leads me to believe that, steroid abuse is a factor, but that all 3 were diabetics. But I'm sure Dr. Pradyumna will also agree with this, that diabetes seems to be extremely important, even a little more, in my opinion, than steroid. Of course, steroid abuse is also a factor.
Sanjay?
Fortunately, no.
Fortunately, no. Actually, that's a good answer. And from our state, from where Dr. Rathi and myself, there are about 23 cases. We have a task force already in place, and very, very aggressively they are working. And unfortunately, there are a couple of cases, about a few cases here in my city. 2 death already we have encountered. I have not personally seen a case of mucormycosis during this particular surge. But actually, last week only there was a case referred to our OPD. We did the biopsy, we did the gram stain. still we are not sure, but probably it is a case of rhinosporidiosis or something, maybe basidiobulomycosis, but may not be a case of mucormycosis. And the patient is not diabetic, and patient is non-COVID, and patient is actually referred from oncology. So we still don't know. And just yesterday we had Abir knows that gentleman, Dr. Arunalak Chakraborty, the famous mycologist from PGI Chandigarh. And Abir, I'm sure you know him. And yeah,
Yes.
very, very respected figure. We had a long discussion from our doctors forum, and there were many unanswered questions. Why we did not have this during the first wave? Why mucormycosis? We do not get the cases in Western Europe and in US. They also have their share of diabetics, and this steroid also was used in UK. So they don't have, like in UK, I have my junior from my college, and she is actually focusing on mycology. Not a single case mucormycosis they have encountered in even in during January or February. Just last night she was chatting with me. So something still we are missing. There are cases coming who are not COVID positive, but diabetes is one of the commonest feature binding all cases of mucormycosis, and the steroid is unmasking this, and there is a unfortunate tendency from many parts of India of giving steroid in patient from the very first day. So we still are a little terrified about this. So
I think Dada, antibiotic abuse also has to be a factor, and I have my suspicions. This is totally ungrounded, but steam inhalation, excessive steam inhalation, which is peculiar for
India.
Indians, I think.
Very important point we discussed with Arunalanta last evening, and probably that is one of the contributing factor.
Even the oxygen thing, which we are
actually
taking,
oxygen
even the water
is not founded. Oxygen, inhalation of oxygen, that is also not a common like a factor for all the patients of mucormycosis, and definitely it is not black fungus. Let us all be very clear about it. It is not black fungus as is stand by Indian media, and so this is not mucormycosis. This is unfortunately a case of tinea. So that brings us to the end of a pretty lengthy and extensive discussion for last more than 1.5 hours, I think. And so let us start our OPD after attending this webinar and reading multiple guidelines. Thank you very much.
Thank you.
And I hand over this
Thank you very much.
to our host, Dr. Vakti from Lupin.
Thank you so much, Doctor. Thank you all of you for that wonderful discussion. I'm sure the audience will have a lot of clinical pearls to take away how to practice now, for the tips and all which you all gave. Thank you everyone for being patient and listening to this interesting conversation.
I warned you before that it will be lengthy.
Sir, it was interesting. Until you told me, I did not realize what time it was. So thank you. I'm sure the audience would also have been glued to their screens, and we'll look forward to more such scientific interactions with you.
Kausikda, now you can ask the number of audience.
Sir, I'll surely
after you go off the air, we'll ask.
Okay.
Sure, sir. I'll let you know.
Okay.
Thank you.
Bye.
Thank you. Thank
So
you,
you can
Kausikda.
stop
Thank you,
recording,
Dr.
then I'll
Abir,
ask
Dr.
you.
Bhatt, Dr. Pradyuman. It was nice missing you all. Bye.
Thank you. Thank you very much. So how was it? So I think our host has also disappeared.
I think it was
going on.
Pallavi, are you
Yes,
here?
sir. It was nice session, sir.
So
The attendance was.
now you also disappeared.
Stop the recording.
I think we are only the 5 doctors we attended.
Yes, but
Thank you, sir. Thanks a lot.
much better now. So
So how many attended? About 100, 150?
It's 200, sir. It's more than 200.
More than 200.
213. 213 is the attendance.
Okay, that's good.
Yes, sir.
Even
Yes,
on
yes.
YouTube as well.
Okay, so
Okay.
bye
Okay.
for now.
Thank you.
Bye.
Bye. Thank you.
Yes,
Bye-bye.
sir. Thank you. Take care. Bye.
Bye. Bye.
Thank you, sir. Thanks a lot.
ये YouTube stream.
How many attended? About